This presentation is adapted from Pulmonary, Sleep, Cardiology, and Critical Care Academy, an online CME-accredited course for advanced practitioners and physicians. Starling's law of the heart, which states that the force of contraction, which translates to stroke volume, is proportionate to preload, but only up to a point. When preload is inadequate to the left of the peak, then the force of contraction, thus stroke volume, is suboptimal, so that fluid resuscitation will move the patient to the right and up the Starling curve with an expected improved myocardial contraction and stroke volume. To the right of the peak, the patient falls off the Starling curve, so to speak, so that additional resuscitation is counterproductive and likely harmful as the ventricular cavity is overdistended. In fact, in many cases, de-resuscitation with diuretics and fluid restriction can paradoxically improve cardiac performance by moving the patient who had fallen off the curve towards the right back towards the peak in the center. The Starling concept is an excellent paradigm to understand the inotropic state of the heart, that is to say, the relative intrinsic contractility of the heart. Let's start with a normal heart shown here in yellow. Disease states that suppress intrinsic cardiac contractility, such as myocardial infarctions or a cardiomyopathy, are said to decrease the inotropic state of the heart and shift the entire Starling curve down so that at any given preload, such as shown here, the contractility of the heart and attendant stroke volume is lower than normal. Conversely, certain medical conditions, such as valvular insufficiency or high catecholamine states, can actually increase the inotropic state of the heart, leading to more vigorous contraction than expected. Not only can medical conditions move the Starling curve up and down, but also certain medications may do the same thing. For example, beta blockers and certain calcium blockers to varying degrees are negative inotropes, moving the curve down as shown in red, while dobutamine or milrinone exert positive inotropic effects on the heart, creating higher contractility, improved stroke volume, and move the curve up as shown in green with positive inotropy, however, sometimes at the expense of increased myocardial oxygen demand and ischemia. So now let's relate Starling's law of the heart to the actin-myosin sliding filament theory. As I showed you earlier, actin and myosin interactions act like springs. Hooke's law of the spring states that the force required to stretch a spring is directly proportionate to the stretch distance, that is, F equals Kx, where F is the force, X is the distance, and K is the proportionality constant, which is referred to as the spring constant. Energy is stored in a spring proportionate to the square of the stretch, that is, energy is 1/2 Kx squared, where E is the potential energy stored in a stretched spring. These laws don't apply at high stress distance when there is a permanent deformity. That is the case where springs don't return to the original state after stretch is released. At the bedside, we can't measure the amount of actin-myosin stretch directly, but we know that stretch rises with LVEDV. Thus, we can use LVEDP as a surrogate for LVEDV. However, when we use LVEDP rather than LVEDV, we must account for two confounding factors, as I previously mentioned. First, LV wall compliance. A low compliance LV is the same thing as a stiff LV, so that the LVEDV for a given LVEDP is lower than it would otherwise have been. I will show you some nice illustrations on this to make it clearer to you in a few minutes. We must also account for the surrounding intrathoracic pressure outside the LV, which could lower the transmural pressure. This is the mechanism of shock caused by cardiac tamponade or tension pneumothorax. In these cases, the intramural pressure of the LV is adequate, but the surrounding pressure is markedly elevated, which squeezes the heart and reduces the effective transmural pressure and underfills the heart in spite of normal LVEDP. I'll show you this in a few minutes with some illustrations. I wanted to leave you with what I feel is the highlight side of this series, where I tie together the actin-myosin sliding filament and Starling's law in one graphic. Imagine a patient who is in shock that has not been resuscitated. On exam, he's hypotensive and tachycardic. He would appear dry and might have orthostatic blood pressure changes with clinical evidence of organ hypoperfusion, such as oliguria or obtundation. At the bedside, a point-of-care echocardiogram would show an underfilled ventricle. If the patient had invasive intravenous catheter monitor, the central venous pressure and pulmonary artery occlusion pressures would be very low, perhaps close to zero. In this state, the actin-myosin fibers are in the unstretched positions and, like a spring that's hardly stretched, stores very little potential energy. Preload is very low, and of course the stroke volume is low, which explains the shock state and compensatory tachycardia. As we resuscitate the patient towards optimal preload, the stretch on the actin and myosin is optimized. However, just like in a spring, there is a limit to how much we can stretch, and if we go too far with over-resuscitation, there is no further overlap in the actin and myosin, and contractile efficiency markedly diminishes, where we say the patient has fallen off the Starling curve. So let's circle back one more time to how we think about preload with respect to Starling's curve and patient management. Although in theory, we would like to know the actual pre-contraction fiber length stretch in myocytes, in reality, that's impossible to measure. So instead of distance, we use left ventricular diastolic end pressure as a surrogate for preload, since we know that as LV-EDV rises, the linear stretch on actin and myosin also rises. Although we have some ways to measure or estimate LV-EDV, most commonly we use LV-EDP, left ventricular end diastolic pressure, as a secondary surrogate for preload. LV-EDP can be measured directly at left heart catheterization and is equal to the left atrial pressure during diastole, assuming there is no mitral stenosis creating a gradient across the mitral valve. We can also indirectly estimate the LA pressure and LV-EDP through a right heart catheterization during a pulmonary artery occlusion measurement, where the LA and LV-ED pressures equilibrate with the pressure in the pulmonary artery after occlusion. However, to optimally use LV-EDP as a surrogate of preload, as I mentioned a few slides ago, we need to account for confounding factors of LV wall compliance and the external pressure around the heart, which could markedly affect preload at a given preload pressure, as I'll show you on the next slide. In this first scenario, the left ventricle, represented here in green, has a normal filling pressure of 12. What we need to think about is that the normal surrounding pressure in the pericardial and pleural space is negative at about -5 centimeters of water, so that the difference between the intracavitary and extracavitary pressure is actually 17 in this example. Let's look at the profile of a patient with hypovolemic shock. No surprise that the filling pressure in this example is low at 2, and with a normal external pericardial pressure of -5, the transmural pressure is also low at 7 relative to about normal of 17 in the prior example. Now let's turn our attention to a patient with low left ventricular wall compliance. Specifically, I mean that their heart muscle is thick and stiff. Compliance is defined by how much volume changes for a given pressure change. In this case, the pressure change is normal with a transmural pressure of 17. However, because the ventricle is stiff with low compliance, it is underfilled. We like to say that patients with stiff ventricles like to have higher filling pressures, so this patient may need to have a filling pressure of 17 or 18 just to have adequate preload. Finally, let's look at an otherwise healthy patient who just sustained a tension pneumothorax from a fractured rib in a motor vehicle accident. Prior to the accident, and even in the emergency department, the patient was euvolemic and had normal left ventricular filling pressures of 12. However, the positive intrathoracic and intrapericardial pressures from the tension pneumothorax create a positive pressure of 10 around the heart compared to a normal value of -5. So in this example, although the filling pressure is normal at 12, the transmural pressure is down to 2, which is a markedly reduced filling pressure similar to what we just saw in the patient with hypovolemic shock. So the take-home measure on this slide is ventricle fills by a combination of transmural pressure, which is affected by both volume and external pressure, and also by left ventricular wall compliance. If you'd like to learn more, please visit our educational center at pulmonaryandsleepacademy.com, where we have 70 hours of self-paced online CME-accredited courses covering pulmonary, sleep, cardiology, and critical care medicine. Please enjoy more of our short visits on our PSA YouTube channel. You can purchase our full courses with an exclusive 10% discount code using YouTube10.